Nomotopic impulse formation abnormality. When we are going to talk about the formation and impulse abnormalities based on the origin, we can talk about nomotopic impulse that is originated from sinus, or not from sinus, it's called heterotopic one. Nomotopic impulse formation can be sinus premature beat, sinus tachycardia, sinus bradycardia, sinus arrest, sinus arrhythmia such as a physiological or respiratory arrhythmia, or sick sinus syndrome. Heterotopic one can be originated from the atrial, very similarly, premature beat, paroxysmal atrial tachycardia, multifocal atrial tachycardia, flutter, fibrillation. And junctional one can be very similarly premature beat, paroxysmal tachycardia, escape rhythm, and junctional acceleration. And ventricular one can be premature beat, paroxysmal tachycardia, flutter, fibrillation, escape beat, escape rhythm, and acceleration. Only flutter and fibrillation can develop in the atrium or in the ventricle, but not in the sinus or in the junction. First, let's look at the sinus premature beat. This is a normal rhythm. We can see that the P's are coming regularly, the PP distance are the same, and the RR distance are the same. What will happen when we do have a sinus premature beat? How do we know that? Because we do have an identical P wave, only this P comes earlier, and the the compensatory pause exactly a normal PP interval. This is why every sinus premature beat is undercompensated. Sinus tachycardia. If we do have an acceleration of this impulse formation in the sinus that's regularly coming and the rate when it's higher than 100 per minute, this is called sinus tachycardia. It can be normal, for example, after load, stress, exercise, emotional stimulus, or can be accompanied in heart disease, fever, hyperthyroidism, pulmonary embolization, drugs, myocardial infarction, and so on, and so on. When you are looking at these strips, you can see these are rhythmic. The heart rate is around 120. We do have P wave in front of every QRS complex that is positive in lead number 2, negative in AVR, and they look the same within one lead. PR interval is normal, and this is why we say that's a sinus tachycardia. The axis, as you see here, 1 positive, AVF positive, so it's normal. Lead number 2 is the biggest one, so it's close to 60. However, because lead number 1 bigger than lead number 3, it has to be around 50 or 40. Sinus arrest. In sinus arrest, the normal regular rhythm is interrupted because the sinus does not make any impulse. So if the sinus doesn't make impulse, the P is missing. And when we do have this gap is usually not the multiple of the PP interval. It's random. But sometimes it can happen that this next beat is originated from a lower center, and we do have an escape beat that usually arises from the AV junction. Sinus bradycardia, similarly to the tachycardia, that's rhythmic, however, the rate is below 60 per minute. Normally occurs in sportsmen during sleep, carotid massage, but it can be pathological, for example, due to endocrine disorders such as a hypothyroidism, or glaucoma, where the intraocular pressure increases, or drugs, sick sinus syndrome, and so on and so on. Looking this strip, you can see that is rhythmic. The heart rate is very slow, 1, 2, 3, 4, 5, 6, almost 7, so it is around 45. We do have P wave in front of every R, and this P is positive in lead number 2, negative in AVR, and they look similar, nice, run-shaped. So this is how we know that this originated from a sinus. So this is a sinus bradycardia. The axis we're looking at AVF is the equiphasic one is positive, so it's around 0. Sinus arrhythmia. Sinus arrhythmia means that we do have an impulse formed by the sinus, however, it's not regular. The rate is altered. There are two forms when we are talking about the most common one, the physiologic one or respiratory sinus arrhythmia, that is normal, usually occurs in young people. During inspiration, the rate is higher. During expiration, is getting lower. Non-respiratory, usually independent from respiration, and it frequently occurs in elderly people. Sixth sinus syndrome. This is a clinical diagnosis, requires clinical investigation. ECG sign, sinus bradycardia, tachycardia changing, sinus stop working, such as sinus arrest, sinuatria blocks again, P suddenly disappearing. So there comes a pause till the sinus starts again working and the P appears again on the paper. Sinuatria blocks, that's a type of the block. When the sinus meets the impulse, however, this is not propagated to the atrial muscle. That's be very similar to the sinus arrest because we do not have P wave, but we had a sinus impulse formation inside the sinus node. Sixth sinus syndrome can be associated with paroxysmal tachycardias, atrial tachycardia, atrial flutter, atrial fibrillation, AV nodal conduction abnormalities, tachybrady that usually causing by ischemia, drugs, cardiomyopathies, amyloidosis, or myocarditis. Looking at the graph, you can see that this is completely arrhythmic. So arrhythmia absoluta, the RR intervals is chaotic and not equal to each other. However, we do see P wave in front of every QRS complex 6, meaning that this arrhythmia is due to sinus impulse formation. So arrhythmia absoluta with normal sinus P wave, that's called sixth sinus syndrome.